The following podcast is part of a certified educational activity titled Prioritizing Weight Management as a Primary Goal in People with Type 2 Diabetes and Office Hours Activity. Access the entire activity and complete the post-test at peerview.com/RWC860. Downloadable slides and practice aids are also available.
Hello, I'm Guillermo Pierres, a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. Welcome to this educational activity on managing glycemia and weight in people with type 2 diabetes. Our goal for today is to equip you and provide you with the evidence or recent evidence to view weight loss as a treatment target in people with type 2 diabetes. First, we're going to review the guidelines. The American Diabetes Association has recommended during the past 5 years a holistic person-centered approach for managing patients with type 2 diabetes. The overall goal is to improve glycemic control to prevent long-term complications and optimize quality of life of people with diabetes. And to do so, first, we need to achieve glycemic management, glycemic control, intensify break inertia, and you can have one or multiple medications. Right now, we have 12 different types of medicine with different mechanisms of action for treatment of diabetes. And we want to improve glycemic control, but at the same time, prevent hypoglycemia. Second, we want to achieve weight loss or weight control. To do so, we need to first set up goals, targets. Second, educate our patients about lifestyle intervention, diet, exercise, and consider medication when it's needed. Third, we want to improve cardiovascular risk factors, blood pressure control, lipid control, antithrombotic agents, and of course, smoking cessation. And finally, during the last few years, we learned about these two group of medicine, the GLP-1 receptor agonists and the SGLT2s, that have been shown to have cardiovascular and renal protection. So this is the holistic approach. Let's concentrate to the figures in the right. To reduce hemoglobin A1C or improve glycemic control, as I mentioned, we have multiple medications which usually start with metformin or combination therapy. But now we know that if the patient already have complications, we should go and treat patients with GLP-1 or GIP, GLP-1 or SGLT2s. When you look at efficacy, the dulaglutide and semaglutide has much better glycemic control than other medications like SGLT2, sulfonylureas, or TZDs. When we look and think about weight loss or reduced weight, the only medication that have really been successful are the GLP-1 receptor agonists and the dual GIP, GLP-1, who has greater efficacy in weight loss. This slide shows the glucose lower agency effect on hemoglobin A1C or glycemic control to the left. And you see that the dual agonist, GIP, GLP-1, together with GLP-1 receptor agonist, has much better glucose control, even better than insulin. In the middle is the effects on weight loss, or body weight in kilograms, with the GLP-1 and the GIP GLP-1 has much greater effects. And of course, we learned throughout the years that insulin is associated with increased weight. And to the right, we have hypoglycemia, where only sulfonylureas and insulin are those who are associated with hypoglycemia, where the GLP and GIP, GLP-1 or dual agonist has much better glucose control, weight control, with no evidence of hypoglycemia. So there is a good correlation between the effects on weight and hemoglobin A1C. For those agents, a GLP-1 or dual agonist, who we see that have much greater effects both in hemoglobin A1C reduction. You can achieve 1.5 to even 2.5% with semaglutide and tirzepatide. While other initial GLP-1 like exenatide, Lilly, has very little weight loss, lower reduction of hemoglobin A1C. This is an important message. The more weight loss, the better in the reduction of hemoglobin A1C. But it's not just hemoglobin A1C. When we combine GLP and dual agonists with diet and exercise, is indicated for all patients with type 2 diabetes. But we also have learned that you can reduce MACE, major adverse cardiovascular events, that include acute myocardial infarction, strokes, and cardiovascular death. And studies with dulaglutide, liraglutide, and semaglutide have shown reduction in MACE. Studies with tirzepatide are ongoing. So not only that you're going to achieve glycemic control, not only that you reduce weight, you can also have an effect on outcome and mortality. So how much weight? This is a question that is usually asked. How much weight do I need to know and need to lose to improve glycemic control? And just 3 to 5% has significant impact in reducing hemoglobin A1C. Even prevent diabetes. Is 3% also reduce triglycerides. You need a little more weight loss to have an impact on blood pressure, metabolic associated hepatic liver disease, 5%, and to improve quality of life, you need to lose 5%. When you talk and see patients who has NASH or non-alcoholic steatohepatitis or apnea, they're related to obesity, you need 10% of weight loss. And if you ever have a patient that loses 10 to 15% of body weight, you're not only going to improve glycemic control, all of these comorbidities that I would mention, but you're going to have effects on cardiovascular mortality and also remission of type 2 diabetes that we're going to talk in a few minutes. The graded weight loss is associated with graded improvement of cardiovascular risk factors as shown in these slides. This is weight loss at 5%, 5 to 10%, or in the green line is more than 15%. And here you have more weight loss is associated with significant reduction. And this is starting with the hemoglobin A1C of 8.5%, you have less than 7%. The same thing for weight, and look at the effects on blood pressure. With significant weight loss of 10 to 15% or more than 15%, you have normalization of blood pressure in the majority of patients with type 2 diabetes. And to the right is the effects on triglyceride. You improve insulin sensitivity and the activity of the lipoprotein lipase, and you can hydrolyze triglycerides and have these effects coming from 200 to less than 140. When we review the results of the clinical randomized studies with the use of tirzepatide, like SURMOUNT and SURPASS, you have the effects on MACE and cardiometabolic outcomes. The pooled tirzepatide doses of 10 and 15 milligrams resulted in reduction of blood pressure about 7 millimeters of mercury, triglyceride reduction about 30% increase in HDL, and a reduction in non-HDL cholesterol. And that cardiovascular risk factor resulted in a trend on a reduction of MACE, major adverse cardiovascular events, myocardial infarction, strokes, and hospitalization for angina. So the same thing, this is with semaglutide. Higher semaglutide doses, the 1 milligram, 2 milligram, have a much better effects on hemoglobin A1C. Here you have to the left is the percentage of patients that achieve a hemoglobin A1C less than 7 is close to 80%. Blood pressure reduction and achieving of blood pressure less than 140, 80%, non-HDL cholesterol, and metabolic composite. Semaglutide had been shown to reduce MACE by 26% in the SUSTAIN 6 study and 21% in the PIONEER 6. This is a reduction of mortality, acute myocardial infarction, and stroke. In addition, semaglutide was recently reported in the New England Journal of Medicine that in patients who has heart failure, preserve ejection fraction, semaglutide resulted in improvement, what is called the Kansas City questionnaire. That's quality of life of people with heart failure. And as you see in the graph to the left, significant improvement as you see these after just a few weeks of therapy. And to the right, semaglutide led to larger reduction of the primary outcome that was improvement of quality of life, improvement of significant symptoms of heart failure, and no hypoglycemia. The FLOW trial was recently published in the New England Journal of Medicine, and it's the first trial, the first randomized controlled trials that investigated on the effect of GLP-1 receptor agonists as a primary kidney endpoint. In the studies, 3,500 patients with type 2 diabetes and chronic kidney disease were included. These patients have a GFR between 25 to 75%, and they had significant albuminuria. And they were treated with semaglutide or placebo. The primary outcome was a composite of cardiovascular and kidney morbidity and mortality. And what they reported is the first major kidney disease event that included a reduction of GFR to less than 15% or the need for dialysis. And that was reduced by 24%. They also reduced MACE, major adverse cardiovascular event, by 18%. And shown in the graph to the right, death from cardiovascular causes was decreased by 20 to 30%. And of course, there was significant weight loss, even in these patients who have high risk because they already have chronic kidney disease. Not only for 24 weeks or 48 weeks, here there are 2 or 3 studies have looked at the effect of long-term utilization of GLP-1. In this case, semaglutide, up to 500 days. There are other studies that are even longer duration. And what you have is that the higher the hemoglobin A1C, you come down to less than 1% reduction, 2% or 2.5%, and the effect is sustained. And to the right is the effects on weight loss. When you took this medicine, it's going to be working and people is able to achieve weight loss and maintain weight loss all the way up to several years. When you compare the effects of tirzepatide versus semaglutide, it was recently reported in these observational studies a benefit of tirzepatide over semaglutide. This data shows at 3 months, 6 months, and 12 months. And pay attention here to the right. The effect of tirzepatide on weight loss was greater than the effect of semaglutide in these observational studies. Let's talk about combination therapy or other agents like SGLT2, GLP-1, and dual agonists, GIP, GLP-1 receptor agonists on weight. So the first thing when we see a patient that is interested in weight loss or you want to help patients to lose weight, the first thing is to set achievable, realistic goals. So improved glycemic control is 3%, but we already said that 10-15% decreased cardiovascular outcome, improved cardiovascular outcome. So we're going to set up your management plan. We're going to discuss about the GIP, GLP-1 therapy, because we know that these are effective as we have discussed. When you talk and you combine, when you think about agents that are being associated with weight loss, you have SGLT2s, a minor reduction of weight loss, but combined with GLP-1 has been shown to improve outcome. You can reduce all-cause mortality and MACE, both with GLP-1 and SGLT2s. GLP-1 have been shown to reduce the risk of stroke. And there is no question that now all of our friends cardiologists are using SGLT2s in patients with heart failure. But it's not only that reduced heart failure hospitalization, it also has cardiovascular and renal protection. In the FLOW study, we saw the effects of GLP-1 on kidneys. Now SGLT2 has been shown to decrease albuminuria and decrease progression of chronic kidney disease. More recently, we learned about tirzepatide, a dual agonist, a GIP, GLP-1, that has good effects on glucose, triglycerides, blood pressure, and all the cardiovascular risk factors. So in meta-analysis, we have seen that the use of SGLT2s and GLP-1 alone or in combination have been shown to be quite effective. What about insulin? The American Diabetes Association during the past 5 to 7 years have recommended that if the time comes for use an injectable, GLP-1 should be preferred over insulin as the first line agent. Why? Because it has similar effects on hemoglobin A1C, but it's associated with weight loss, no risk of hypoglycemia. Unfortunately, these are complications or side effects that we see with insulin therapy. But the combination, when glycemic control is not achieved, or when the patient has cardiovascular risk factor, the combination of insulin or GLP-1 should be considered. They have complementary approach to reduce hemoglobin A1C, increase insulin, decrease glucose, increase glucose uptake in peripheral tissues, and decrease hepatic glucose production with the combination of basal insulin. In addition, you have decreased appetite, slowing gastric emptying that improve postprandial glucose control. In this presentation that was just recently published in Postgraduate Medicine, applies the 3 E's, and I think this is extremely important to keep in mind when we consider the treatment with GLP-1 or the dual agonist GIP, GLP-1. So the 3 E's includes education and explanation. You have to tell the patient about what is anticipated. The gastrointestinal adverse event, that's where we start a low dose, that's the escalation. You start a low dose, and every month you're going to increase the dose as tolerated when the gastrointestinal adverse event goes away. And the 3rd E is effective management of GI adverse events. We have to tell the patient to be hydrated, increase fibers, decrease fat and fat intake or the fatty meals, and eat slowly, and the patients are going to have decreased gastrointestinal adverse events. So let me move now to weight loss as a tool for diabetes remission. So this slide, I think we all diabetologists have seen this slide because it's like 20 years old. And what it shows is the type 2 diabetes progression in relation to beta cell function. For at the time of diagnosis of diabetes, we believe our study has shown that there's significant beta cell function, maybe 40–50% is already lost. So for diabetes prevention, it's easy when you have good beta cell function. Diabetes remission can be achieved during the first 5 to 10 years, within the first 10 years of the initial diagnosis of diabetes, because you still have beta cell function. Now, it is very hard to know when diabetes type 2 starts. But if the diagnosis is made and you have somebody has 5–10 years, you can achieve diabetes remission in a significant number of patients with type 2 diabetes with weight loss on medications. So what is diabetes remission? The Endocrine Society and the European Association of Study of Diabetes and the UK Diabetes recently had a consensus definition. Is sustained metabolic improvement in type 2 to near normal levels of hemoglobin A1C, so hemoglobin A1C less than 6.5%, that is achieved with no diabetes medicine for at least 3 months. So this is a good definition because we know that we can achieve glycemic control and normalization of hemoglobin A1C. There is significant reduction on the risk of complications. In the pool analysis of 4 U.S. single centers randomized control studies that investigated the long-term effects of weight loss. And here you see a comparison between bariatric surgery and medications. These studies were done before the availability of GLP-1 and the dual GIP-GLP-1. And of course, bariatric surgery is much more effective than old medicines. You can achieve 50–60% reduction or remission of diabetes with surgery. 2 years and 5 years later, unfortunately, only 30% to 40% of patients with bariatric surgery is still in remission. And medications, can you achieve remission? Yes, if you lose weight. But it's not only medication. There are studies like the DIRECT trial in the United Kingdom that have shown that significant weight loss with diet of 800 to 850 calories. When they lose 5 to 10 kilograms, up to 15 kilograms, you see a remission in somewhere around 50 to 60%. And if somebody loses 15 kilos or more, in patient who has short duration of diabetes, less than 10 years, about 80% can achieve diabetes remission. At year 2, there is some decrease in remissions, but you can achieve, if somebody still lose more than 10 kilograms, 60 to 70% of patients with just diet intervention achieve remission. So hemoglobin A1C less than 6.5, no medication for diabetes. The DIRECT trial recently published the 5-year data. And even after 5 years, those who continue to lose weight or maintain the weight loss achieve remission is somewhere around 25%. So lifestyle intervention is important to achieve remission. The same thing was published many years ago, and this was through a look-ahead trial, an NIH trial that had intensive intervention in patients with type 2 diabetes. And unfortunately, it's not as successful in weight loss as we see with the DIRECT trial, but somewhere around 10 to 12% of patients achieve remission. And this is remission after 3 and 4 years. This decrease is very, very low because it's very hard to maintain body weight. And here you have the effects on hemoglobin A1C, and to the right, the change in body weight in the look-ahead trial. The primary outcome of the look-ahead trial was decreased cardiovascular complications. That was not observed. When you see the hemoglobin A1C, unfortunately, it has a very nice reduction in the first year, but progressively increases the hemoglobin A1C up to the year 10. And the same thing happened with weight. Lifestyle intervention resulted in significant reduction of body weight, somewhere around 8 to 10 kilograms. But unfortunately, with increased duration of intervention, they observe an increase in body weight. So lifestyle modification is the foundation of weight management. We should always start with lifestyle. But we have now medications because we know that achieving and maintaining weight loss is difficult with just lifestyle. There are agents like oral semaglutide or SGLT2s. And here you have the effects of DAPA with weight. To the left is hemoglobin A1C. And here you have the combination of DAPA and semaglutide. And you see that it's a nice effect on hemoglobin A1C and reduction. But DAPA by itself, SGLT2 is associated with 2 or 3 kilograms max of weight loss. But now we have medicines that are extremely effective in weight control, like tirzepatide, the dual agonist, GIP, GLP-1. And when you look at here is those, if you treat patients with type 2 diabetes, to the left, the percentage of people who has achieved a hemoglobin A1C less than 7% with no weight gain and no hypoglycemia. And you have 80 to 90% of them achieve control. In that studies were compared with insulin. And unfortunately, insulin is not very good in achieving glucose control and maintaining glucose control, and of course, it's associated with weight gain. So when you look at the right, it's achieving hemoglobin A1C target less than 7%. The use of tirzepatide resulted in 80 to 90% effective in reducing hemoglobin A1C. So when you look at all of these trials, randomized control trials with tirzepatide, you can achieve normal glycemia and hemoglobin A1C less than 5.7%. And you see here that compared to placebo, when you look at here versus all of the different trials and different medications, tirzepatide was effective in improving glycemic control and increased the odds of maintaining normal glycemia, hemoglobin A1C less than 5.7%, 16 times better than other agents. Some practical recommendations that you can use when you're in your clinic. First, we have seen this slide for the last few years, have been little modifications, but these are the recommendations of the American Diabetes Association standard of care for the management of patients with type 2 diabetes. To the left, you have a cardiovascular risk reduction. Now we also have heart failure reduction and reduction of kidney complications. So in patient who has multiple risk factors or established cardiovascular disease, the recommendation is to start on a GLP-1 and SGLT2. If it's necessary for glucose reduction, you can add metformin or other agents. For heart failure, we know that SGLT2 reduce the admissions to the hospital and reduce mortality by 20 to 25% in patients with heart failure. Now, we also show that GLP-1 may also help in patients with heart failure. For chronic kidney disease, those patients who have decreased GFR less than 60 or the presence of albuminuria, the first line agents and recommendation is the use of SGLT2s. But I also just show you the flow studies that the GLP-1 has a beneficial effects in cardiovascular mortality in patients with chronic kidney disease. The second part of this recommendation of the American Diabetes Association is weight maintenance. So this is extremely important because obesity is the reason why we have so much diabetes. And we should avoid medication associated with weight gain and use medicine and educate patients and start lifestyle intervention with or without medication for weight loss. An agent that associated with significant weight loss are the GLP-1 receptor agonists and the dual agonist GIP-GLP-1. This table shows the different GLP-1 receptor agonists and the dual agonists on the doses that are available, medications that are right now on the market, and you see that you can go and the most important thing is to start low dose and start increasing the dose, usually in every 2 to 4 weeks as tolerated. The gradual increase of doses reduces significantly gastrointestinal adverse events and acceptability of the patient to continue to take this medicine. Because we know that if you stop these medications, there is weight regain. And finally, how do you talk to your patient? So first, save time and dedicate the time to talk to your patients about what is expected, what are the goals, tell them about potential adverse events, the GI adverse events, the importance of start slow and dose escalation. So you have to wait for 2 to 4 weeks. You also have to tell the patient that try to avoid these large fatty meals because that may be associated with increased gastrointestinal adverse events. And the maintenance phase is extremely important, right? See the patients or send the patient to the dietitian, to the nutritionist to help about food selections that may be associated with greater weight loss. If the patient has gastrointestinal adverse event, well, you can use antiemetic or prokinetics. If you have always decreased the dose, if you have constipation, use stool softener, consider reducing the GLP-1 dose. So these slides are available to you. So the key message to take away, there are now medications that regulate glycemia. We have 12 different groups of medicine that help us to glucose control. But now we have medications that are highly selective that also produce weight loss. The GLP-1 receptor agonist and the GIP-GLP-1 receptor, the dual agonist, not only improve glycemic control, not only decrease weight, that have been shown to improve cardiovascular outcome, the MACE, major adverse cardiovascular events, decrease mortality, improve kidney function. So the goal and the future of diabetes control is weight control Used selective agents have been shown to have cardiovascular and renal protections and decrease cardiovascular mortality. I thank you so much for your attention. Thank you so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/RWC860.